HSM 801, page 729. Healthcare Financing in Nigeria by Dr. I.D. Alabere, MNI. Outline, Introduction, Universal Health Coverage, Healthcare Financing in Nigeria, Health Insurance, Community-Based Health Insurance. Introduction. Primary objective of most healthcare systems is to provide health services that optimize the population's health and the provision of safe and quality healthcare that contributes significantly to healthier populations. Nambia, 2017. Currently, at least half of the people in the world do not receive full coverage of essential health services they need. About 100 million people are pushed into extreme poverty each year, defined as living on $1.90 or less a day because of out-of-pocket spending on health, which should not be the case. Over 800 million people, almost 12% of the world's population, spend at least 10% of their household budgets to pay for health care. This level of expenditure is not sustainable for most families, particularly the poor that constitute the majority of the population in developing countries. WHO defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It further asserted that physical and mental well-being is a human right that enables life without limitation or restriction. WHO 1948. It also considered health as a resource for everyday life and not the objective of living. WHO 1984. Healthcare, on the other hand, refers to efforts made to maintain or restore physical, mental, or emotional well-being, especially by trained and licensed professionals. It is the maintenance or improvement of health through prevention, diagnosis, and treatment of disease, illness, injury, and other physical and mental impairments in people by services offered by health professionals. It therefore means that all the individuals need to have unlimited access to healthcare services to remain healthy, so as to have good health, which is a resource needed for everyday living. This is, however, not the case, as most people do not have access to quality healthcare whenever needed, due mainly to financial barrier, as healthcare is paid for out of pocket in most countries, particularly developing countries, including Nigeria, where the proportion of people who are economically defined as poor is staggeringly very large. This implies that the assertion physical, mental well-being is a human right that enables life without limitation or restriction. WHO 1948 is not attainable. To make health for all a reality, there is need for individuals and communities to have access to high-quality health services so that they can take care of their own health and the health of their families. To redress this, all United Nations member states have agreed to try to achieve universal health coverage (UHC) by 2030 as part of the Sustainable Development Goals. Specifically, Sustainable Development Goals 3, Target 8 is dedicated to universal health coverage. Universal health coverage. UHC means that all individuals and communities receive the health services they need without suffering financial hardship. It includes a full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. UHC enables everyone to access the services that address the most significant causes of disease and death, and ensure that the quality of those services is good enough to improve the health of the population of the people who receive them. Protecting people from the financial consequences of paying for health services out of their own pockets reduces the risk that people will be pushed into poverty because unexpected illness requires them to use up their life savings, sell assets, or borrow, thus destroying their futures and often those of their children. Achieving universal health coverage is one of the targets of the nations of the world set when adopting the Sustainable Development Goals in 2015. Countries that progress towards the UHC will make progress towards other health-related targets and towards all other goals. Key features of UHC. Sustainable Development Goal 3.8. Achieve universal health coverage, including financial risk protection, access to quality essential health care services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. The indicators for SDG 3.8 are Indicator 1, Indicator 3.8.1, coverage of essential health services, defined as the average coverage of essential services based on tracer interventions that include reproductive, maternal, newborn and child health, infectious diseases, non-communicable diseases, and service capacity and access among the general and the most disadvantaged population. 2. Indicator 3.8.2, proportion of population with large household expenditures on health as a share of total household expenditure or income. Universal health coverage is a goal that all people obtain the health services they need without risking financial hardship from unaffordable out-of-pocket payments. Additionally, UHC aims to create a system of protection which provides equal opportunity for people to enjoy the highest possible level of health. The three key features are: 1. Coverage with the full spectrum of health services according to need, with good health services ranging from health promotion to prevention, treatment, rehabilitation, and palliation. This implies equity in access to health services. Those who need the services should get them, not only those who can pay for them. 2. Coverage with a form of financial risk protection from direct payment for health services when consumed. 3. Universality. Coverage for the entire population, that is, should be for everyone. According to WHO, healthcare system goals are: 1. Provision of good health for the citizens. 2. Responsiveness to the expectations of the population. 3. Fair means of funding operations. Health financing is therefore a core function of health systems that can enable programs towards universal health coverage by improving effective service coverage and financial protection. Healthcare financing is the mobilization of funds for the provision of healthcare services, or YFAB Aliyu and Idris 2014. That is, the provision of funds or resources to the activities designed to maintain people's health. The major expenses of most healthcare systems are human resources, care at hospitals, and medications. WHO's approach to healthcare financing focuses on three core functions. 1. Revenue raising, that is, sources of funds including government budgets, compulsory or voluntary prepaid insurance schemes, direct out-of-pocket payments by users, and external aid. 2. Pooling of funds, that is, the accumulation of prepaid funds on behalf of some or all of the population. 3. Purchasing of services, that is, payments or allocation of resources to health service providers. Generally, there are 6 mechanisms of healthcare financing. 1. General revenue or earmarked taxes. 2. Social insurance contributions. 3. Private insurance premiums. 4. Community financing. 5. Direct out-of-pocket payments. 6. Donations and aids. Each method distributes the financial burdens and benefits differently. Additionally, each method affects who will have access to healthcare and who gets financial protection. So look at them one after the other. General revenue or earmarked taxes. This is the most traditional way of financing healthcare. It is used to finance a major portion of healthcare, especially in low-income countries, including Nigeria. Government schemes, for example, typically receive budgetary allocations out of the several government revenues, e.g. from income and corporate taxation, value-added tax, special tax on certain consumer products, including tobacco and alcohol taxes, etc. Social health insurance. Social health insurance is usually financed out of social contributions payable by employees and employers. However, these schemes may also receive a varying proportion of their revenues from governmental transfers. It is usually compulsory, that is, everyone in the eligible group must enroll and pay a specific premium contribution in exchange for a set of benefits. Social health insurance premiums and benefits are described in social compacts established through legislation. Besides premiums, there could be co-payments for all or some services. Premiums or benefits can be altered only through a formal political process. Private insurance. Private contracts offered by an insurer to exchange a set of benefits for a payment of a specified premium, marketed either by a non-profit or for-profit insurance companies. Consumers voluntarily choose to purchase an insurance package that best matches their preference, offered on individual and group basis. Under individual insurance, the premium is based on that individual's risk characteristics, that is, there is risk assessment to determine the amount of premium to be paid. The main sources of revenue for private health insurance are either compulsory or voluntary prepayments, which typically take the form of regular premium payments as part of an insurance contract. Major concern in private insurance is buyer's adverse selection. Under group insurance, the premium is calculated on a group basis. Risk is pooled across age, gender, and health status. Community-based financing refers to schemes based on 3 principles. 1. Community cooperation. 2. Local self-reliance. 3. Prepayments. Factors for sources of community financing. 1. Technical strength and institutional capacity of the local group. 2. Financial control as part of the broader strategy in local management and control of healthcare services. 3. Support received from outside organizations and individuals. 4. Links with other local organizations. 5. Diversity of funds. 6. Responding to other non-health development needs of the community. 7. Ability to adapt to a changing environment. Direct out-of-pocket payments made by patients to private providers at the time a service is rendered. User fee is referred to fees the patients have to pay to public hospitals, clinics, and health posts, not to private sector providers. Out-of-pocket payments and or user fees are exclusively financed from household revenue. Proponents of user fees believe that the fee can increase revenue to improve the quality of public health services and expand coverage. Major objection raised against user fees has been on equity grounds. Donations and aids. Developmental Assistance for Health (DAH), also known as AIDS, is financial and in-kind contributions transferred through major development agencies to low and middle-income countries for maintaining or improving health as part of bilateral cooperations with foreign governments or other development partners. Besides the traditional donor countries, who are usually members of the Organization of Economic Cooperation and Development (OECD), Development Assistance Committee (DAC), and usually high-income countries, several other middle-income countries have gradually emerged in the global health financing arena. The assistance is usually channeled through national agencies for bilateral and multilateral programs. Common agencies are USAID, DFID, JICA, etc. The assistance provided to low and middle-income countries are usually for specific intervention, e.g., TB, leprosy control, malaria, HIV/AIDS, and maternal, newborn, and child health, onchocerciasis control. Donations are contributions, grants, payments in cash or in kind equipment, medical consumables made without expectation of something in return other than customary donor recognition of incidental value. Some of the health donors are UNICEF, the World Bank, WHO, UNDP, UNAIDS, etc. The international community's contribution to global health comes in various forms, namely financial assistance, loans and grants, commodities, drugs, medical equipment, technical expertise, training, study tours and fellowship, research funding, among others. Donations also come from philanthropists, NGOs, private sector organizations. Donations are for general or specific purposes, e.g. for the efforts of controlling COVID-19. Healthcare financing in Nigeria. There are various sources of healthcare financing in Nigeria. These sources include, but not limited to: 1. Tax-based public sector health financing; 2. Household out-of-pocket health expenditure; 3. The private sector (AIDS and donor funding); 4. Social health insurances; 5. Community-based health expenditure. External financing of healthcare includes grants and loans from donor agencies like the World Bank, WHO, and Foundation, among others. Tax-based public sector health financing. This source of healthcare financing is derived from proceeds of tax-based revenue of governments across all levels and sectors. At the federal level, the pool of taxes entails crude oil and gas exports proceeds, petroleum profit tax, royalties, imports, and excise duties, and the component proceeds of domestic crude oil sales / other oil revenues, companies income tax, value-added tax, VAT, tax on petroleum products, education tax, among others. Onotai and Wanko, 2012, Abansa and Orimisan, 2013, Yunusa et al., 2014. Financing of the healthcare by governments is largely a function of its revenue base. In essence, there is a strong positive relationship between the proportions of tax-based health spending and the progressivity of total health expenditure. One of the foremost advantages of tax revenue is the pooling of health risk across a large contributing population, saved off 2004. Another implication of raising funds through taxes is that contributions are usually spread over a larger share of population than might otherwise be the case. The disadvantage of the tax-based system of health care financing is that there are usually competing needs for the same revenue, and therefore budgetary allocations are usually not sufficient to finance health care. Out-of-pocket health expenditure. Out-of-pocket health expenditure, OOP, is also referred to as user charges. The health facility owners impose some charges on individuals for healthcare services uptake. OOP health expenditure could be incurred directly by patients to a health service provider to cover the on-the-spot payments for healthcare services received. The scope of individual health user fees could be an admixture of drug costs, medical material costs, registration fees, and consultation fees. OOP payment, otherwise known as private health expenditures, accounted for more than 90% costs in accessing health in Nigeria. Consequently, those who cannot afford the fees are likely to stay away from healthcare uptake. This can exacerbate the already inequitable access to quality care. Given the high poverty situation in Nigeria, healthcare spending on some debilitating illnesses can be catastrophic. It is catastrophic if OOP exceeds the household income or its capacity to pay for healthcare services received. In other words, a large proportion of the household budget goes into the health expenditure, thereby leaving little to meet other basic health components like food, shelter, education, hygiene. In terms of measurement criteria, catastrophic health expenditure is when OOP on healthcare expenditures exceed 40% of non-subsistence expenditure. Catastrophic health expenditure for any household may further push it into poverty. In extreme situation, the implication of a very high level of OOP on healthcare spending is that a significant proportion of the poor may be driven into squalor after paying for healthcare. A chronic ill health situation that afflicts the breadwinner of the family may completely impoverish it, especially those who sell their labor on a daily basis to fend for their families. Even the non-poor may be impoverished by large random out-of-pocket payments arising from unpredictable ill health. Medical improvements and catastrophic health expenditures are the likely outcome of over-reliance on OOP health spending. Incidence of catastrophic health expenditures is said to be generally greater in the rural areas compared to the urban areas. Similarly, the socio-economic status of a household corresponds with its monthly catastrophic total household health spending, with the poorest having the highest incidence of catastrophic expenditures. Other issues associated with OOP health expenditure include gender, age, income level, family size, nature of illness, healthcare services utilization, among others. Private sector (donor funding). In view of the enormous demand for the funding of healthcare, government alone cannot shoulder the responsibility of good and quality healthcare provision, given the dwindling economy culminating in a very poor budgetary allocation to the health sector. Therefore, it has become imperative to engage the private sector in financing healthcare in Nigeria. Private sector health financing include the donor funding as well as public-private partnerships. Some of the health donors are UNICEF, the World Bank, WHO, UNDP, UNAIDS. The international community's contributions to global health come in various forms, namely 1. Financial assistance (loans and grants), 2. Commodities (drugs, medical equipment), 3. Technical expertise, training, study tours and fellowship, research funding, among others. Besides these major funds from the aforementioned organizations, agencies and countries, global public-private partnerships that tend to focus on specific diseases or health conditions have proliferated. Some of these foundations include Gavi Alliance, the Global Fund, the Medicines for Malaria Venture, and the Partnership for Maternal, Newborn and Child Health, etc. However, private sector health financing is not without its challenges. One of the persistent challenges is duplication of financing efforts by the donor agencies and foundations, coupled with lack of global coordination among donor agencies in sending healthcare aids to the developing countries. Health insurance. The term health insurance is generally used to describe a form of insurance that pays for medical expense. It is sometimes used more broadly to include insurance covering disability or long-term nursing or custodial care needs. It may be provided through a social insurance program or from private insurance companies. It may be obtained on a group basis, e.g. by a firm to cover its employees, or purchased by individual consumers. In each case, premiums or taxes protect the insured from high or unexpected health care expenses. By estimating the overall cost of healthcare expenses, a routine finance structure such as a monthly premium or annual tax can be developed, ensuring that money is available to pay for the healthcare benefits specified in the insurance agreement. The benefit is typically administered by a government agency, a non-profit health fund, or a commercial corporation. Many commercial health insurers control their costs by restricting the benefits provided by such means as deductibles, co-payments, co-insurance, policy exclusions, and total coverage limits. They will also severely restrict or refuse coverage of pre-existing conditions. Many government schemes also have co-payment schemes, but express exclusions are rare or limited because of political pressure. The larger insurance schemes may also negotiate fees with providers. Many forms of social insurance schemes control their costs by using the bargaining power of the community they are intended to serve to control costs in the healthcare delivery system. They may attempt to do so, for example, negotiating drug prices directly with pharmaceutical companies, negotiating standard fees with the medical profession, or reducing unnecessary healthcare costs. Social schemes sometimes feature contributions from related to earnings as part of a scheme to deliver universal healthcare, which may or may not or involve the use of commercial and non-commercial insurers. Essentially, the wealthier users pay proportionately more into the scheme to cover the needs of the poor users, who therefore contribute proportionately less. There are usually caps on the contributions of the wealthy and minimum payments that must be made by the insured, often in the form of a minimum contribution similar to a deductible in commercial insurance models. In addition to these traditional healthcare financing methods, some lower income countries and development partners are also implementing non-traditional or innovative financing mechanisms for scaling up delivery and sustainability of healthcare, such as micro contributions, public-private partnerships, and market-based financial transactions and taxes. For example, as of June 2011, UNITAID had collected more than $1 billion from 29 member countries, including several from Africa, through an air ticket solidarity levy to expand access to care and treatment for HIV/AIDS, tuberculosis, and malaria in 94 countries. Health insurance is a system of advanced financing of health expenditure through contributions, premiums, or taxes paid into a common pool to pay for all or part of health services specified by a policy or plan. Health insurance is broadly classified into 1. Private health insurance. 2. Social health insurance. Private health insurance. This is a health insurance system that is risk-based for both financial and health by the enrollee. It is therefore a form of actuarial insurance. The contribution is determined by health risk, that is age, family history of illness, or current health status. It is organized and administered by an insurance company or other private agency with the provision specified in a contract. It is private and voluntary. Social health insurance. This is a system of health insurance that is financed by compulsory contributions, which is mandated by law or by taxes. The provisions of the system are specified by legal status. In social insurance, the contribution is not determined by health risk, that is age, family history of illness, or current health status. It is based on the individual's ability to pay. It is not profit-based. National Health Insurance Scheme of Nigeria is an example of social health insurance. National Health Insurance Scheme of Nigeria. In response to the deplorable national health indices and poor access to quality health care by the generality of Nigerian citizens, coupled with the high poverty rate, Decree 35 of 1999, Act 35 of 1999 was promulgated that established the National Health Insurance Scheme (NHIS), became operational in 2004. The Act was amended to form the National Health Insurance Authority Act of 2022. Objectives of the NHIS. A. To ensure that every Nigerian has access to good healthcare services. B. To protect families from financial hardship of huge medical bills. C. To limit the rise in healthcare costs. D. To ensure the equitable distribution of healthcare costs among different income groups. 5. D.E. To maintain high standard of healthcare delivery services within the scheme. F. To ensure efficiency in health services. G. To improve and harness private sector participation in the provision of healthcare services. H. To ensure adequate distribution of health facilities within the Federation. I. To ensure equitable patronage of all levels of healthcare. J. To ensure the availability of funds to the health sector for improved services. To ensure that all Nigerians have access to good healthcare services, the NHIS developed programs under 4 broad categories to cover different segments of the society, namely 1. formal sector social health insurance programs. Under that, you have A, public sector. It includes federal, state, and local government staffs and their families. Local government staff and their families. B, organized private sector. C, armed forces, police, and other uniformed services. Number 2, students of tertiary institutions social health insurance programs. Number 3, informal sector social health insurance programs. The programs in this sector cover employees of companies with 10 or less staff, artisans, voluntary participants, rural dwellers, and others not covered under the formal sector or vulnerable group. Under this, we have A, community-based health insurance programs, and B, voluntary contributions social health insurance programs. Number 4, voluntary group social health insurance programs. Under that, you have A, physically challenged, B, prison inmates, C, children under 5, D, refugees, victims of human trafficking, internally displaced persons, and immigrants social health insurance program. F, pregnant women. It is important to note that some of the beneficiaries in the voluntary group, namely children under 5 and pregnant women, are also covered under the formal and informal sectors program. The various programs on NHIS operate under a 4-tier system. 1, the NHIS administration. 2, health management maintenance organizations, HMOs. 3, service providers. And 4, enrollees. National Health Insurance Authority Act of 2022. Whereas the National Health Insurance Scheme Act of 2004 provided for the establishment of a National Health Insurance Scheme, the National Health Insurance Authority Act provides for a National Health Insurance Authority. NHI Act of 2022 created a body corporation sole for the administration of health insurance schemes across the nation. Remarkably, under NHI Act, wider powers have been granted to National Health Insurance Authority to, among other things, acquire, hold, or dispose of any movable and immovable property, as well as enter into contracts or any other transactions in pursuance of its powers and functions under the NHI Act 2022. The authority established by Section 1 of the NHI Act 2022 shall be headed by a Director General, who shall be the Chief Executive Officer of the authority. The functions of the authority are diverse and shall be exercised with a view to achieve universal health coverage for all Nigerians by ensuring that the health insurance is mandatory for all Nigerians and legal residents in Nigeria. The authority shall have the number of directors which the governing council believes are required to assist in performing its functions. The authority shall also have employees, and its activities shall be administered from a fund known as the fund. Such funds shall be subject to annual accounts and audits. The authority shall also have an office in all states of the Federation. National Health Insurance Authority have continued. Establishment of the Governing Council and powers. The Act maintains in part the provisions of the repealed NHIS Act 2004 by also re-establishing a Governing Council which shall be headed by the Chairman, Secretary, who shall be the Director General of the authority and consist of such other members as stipulated by the Act. The NHIA Act introduces changes into the constitution of the Governing Council by including 1, representativeness from each geopolitical zone to represent the states on a 2-year tenure on a rotational basis. 2, a representative of civil society organizations whose main activities focus on health. 3, a representative from the armed forces. 4, 2 representatives from organized labor. The NHI Act, however, omits the provisions for representatives of registered health maintenance organizations, private healthcare providers, persons to represent public interests. All members of the council are part-time members except the Director General. Upon appointment, members of the Governing Council shall disclose their interests and shall not hold personal interests in organizations under the Act. The Governing Council shall have the powers to approve and register third-party administrators, ensure effective implementation of policies and guidelines of the authority, regulate various health insurance schemes under the Act, and undertake approval, licensing, regulation, supervision of organizations and institutions relating to the authority. Where necessary, the council may constitute a committee of members and non-members. However, if the committee is made up of non-members, it shall only act in an advisory capacity. Where the president deems fit, it may dissolve the council and all these members cease to become members except the Director General. Provision for the establishment of the state health insurance schemes. Another significant innovation of the NHIA is the provision for establishment of state health insurance schemes or state contributory schemes. The NHIA Act envisages a multi-player collaboration between all stakeholders, viz. State health insurance schemes, private health insurance schemes, health maintenance organizations (HMOs), healthcare providers, third-party administrators (TPA), contributors, mutual health organizations/associations (MHAs). These stakeholders are to work in accordance with the operational guidelines to be issued by the authority towards ensuring access to healthcare for all Nigerians. The NHIA Act decentralizes health insurance schemes. It provides a three-strata level of health insurance, which are 1. National Health Insurance Scheme for employees at the federal level to be accredited and administered by the National Health Authority. 2. The state health insurance schemes. 3. The private health insurance schemes. Provision for the establishment of state health insurance schemes continued. All the states of the Federation and FCC are enjoined to establish and implement a state health insurance and contributory scheme with a minimum scope of coverage as outlined in the Basic Minimum Package of the National Health Act, while the National Health Insurance Authority shall establish a scheme for the coverage of all employees in the Federal Civil Service. The state health insurance scheme shall ensure that all HMOs, MHAs, and TPAs employed under their schemes are registered. States that set up the health insurance schemes shall be entitled to participate in allocations from the Basic Healthcare Provision Fund as provided for by the National Health Act and its guidelines. If a state does not have an established health insurance scheme, it may contact a TPA to administer a scheme on its behalf. Provision for vulnerable persons and funding. The National Health Act provides for coverage by vulnerable persons who shall not be liable to payment of premiums by establishing the Vulnerable Group Fund. Such vulnerable persons are defined by the Act to include children under 5, pregnant women, the aged, physically and mentally challenged, and the indigent as may be defined from time to time by the Council. The payment of coverage for vulnerable groups and the subsidy of health insurance premiums for indigent groups persons shall be made from the Vulnerable Group Fund. The sources from which funds shall accrue to the Vulnerable Group Fund include 1. The Basic Healthcare Provision Fund. 2. Health Insurance Levy. 3. Telecommunications tax not less than 1 kobo per second of GSM calls. 4. Money that may be allocated to the VGF by the government. 5. Money from investments made by the governing council. 6. Grants, donations, gifts, and other voluntary contributions subject to review by the council by regulations to ensure that the sources of funds keep pace with developments in the health insurance industry. Payments, distributions of the VGF shall be made pursuant to the directives of the council. Public-private partnership, private health maintenance and insurance organizations. To promote public-private partnerships and private enterprises, the Act permits for the registration of private health insurance schemes. The person who wishes to operate such private health insurance scheme must be a registered limited liability company limited by guarantee. Such entities shall apply for license and accreditation. The private health insurance schemes must deposit in an interest-yielding account designated by the authority. An amount to be applied to meet its liability where it cannot meet liabilities to contributors from available sources or in case of winding up or closure. By this provision, health maintenance organizations existing before the commencement of the Act must now take steps to register and be accredited under the NHIA Act. Additionally, the NHIA Act preserves all existing contracts and acts validly made under the previous National Health Insurance Scheme Act. Thus, all such contracts remain valid and shall continue to operate as though they were made under the new Act, provided they were validly made. Accreditation of HMOs, MHAs, and TPAs under the Act shall be according to operational guidelines to be issued by the authority. The authority retains the right to withdraw the license of an HMO, MHA, or TPA and decide on how to keep the concerns of the organization ongoing. These organizations shall be licensed and must display their licenses in prominent places in their offices. The HMOs may flag private health insurance schemes subject to approval by the authority. Mutual health organizations shall engage in community mobilization and sensitization, and in consultation with the authority shall assist in ensuring the interests of its members are protected. Where there is a dispute between HMOs, healthcare providers, the authority, contributors, or its agencies, recourse shall first be made to mediation and conciliation, and where this fails, to arbitration. Where legal action lies against the authority, its agents, or employees, pre-action notice should be issued 1 month prior to the commencement of such action. Mandatory insurance for all Nigerians. The NHIA Act 2022 makes insurance mandatory for every Nigerian resident, including employees in the informal sector. Employers and their employees shall be registered pursuant to regulations made under the Act. The Act compels employers who have 5 or more employees to contribute to a health insurance scheme. However, an individual may register with and obtain a private health insurance scheme, provided that such person shall not be entitled to cover under the Vulnerable Group Fund. Offences. Penalties and offences are created for 1. Failure to pay contributions deducted by an employer within stipulated period. 2. Non-remittance of the contributions deducted from an employee. 3. Non-remittance to healthcare providers. 4. Failure to settle fee for service. 5. Manipulation of enrollee register. 6. Issuance of due checks. 7. Failure to provide care. Under the Act, monetary fines and or term of imprisonment applies to the offences listed above. Community-based health financing. This is also referred to as community-based health insurance, CBHI. It is designed to provide financial protection from the cost of seeking health care. It has 3 components, namely 1. Prepayment for health services by community members. 2. Community control. 3. Voluntary membership. Examples of CBHI in Nigeria is Hygia Community Health Plan, HCHP, that are run in Lagos and Kwara states respectively, under the auspices of an international health non-governmental organization, NGO. The Obio Cottage Hospital and Rumu Urushi Primary Healthcare Schemes operated by SPDC are other examples. Community-based social health insurance program definition. This is a non-profit health insurance program for a cohesive group of households, individuals, occupational groups that are formed on the basis of ethics of mutual aid and the collective pooling of health risks in which members take part in its management. Membership. Membership is voluntary and open to all residents, that is, families of the participating community or occupation-based group, including retirees. The individual or family is the unit of registration to achieve a pool of funds to ensure viability and also to address the problem of adverse selection. Communities or occupation-based groups are to have at least 50% of members with a minimum of 1,000 members willing to participate. Registration. Enrollees are registered by a technical facilitators or board of trustees (BOT). Any program under CBHIP is to have a clearly defined procedure for registering enrollees and a means of identification, e.g. membership card, to assist in the identification of scheme members. Benefit package. This reflects preventive, promotive, and curative components of healthcare delivery. It is to cover at the minimum primary and secondary curative care, taking into cognizance the prevailing local morbidity and mortality profile, including pre- and postnatal care, normal delivery, child welfare services, immunization, family planning, and health education. Contribution. This is an actuarially determined flat rate for each household/individual household, member of an occupation-based group. The determined amount or premium is paid in cash monthly, seasonally, or annually in advance. Donations. Project managers with BOT and facilitators may seek for donations and grants through formal launching, fundraising, or by targeted individuals, governments, and civil society organizations, including private companies, with a view to boosting the financial base of the scheme. Management models. There are basically three models. 1. A. BOT as program managers. B. BOT as program managers with external technical facilitators. C. Technical facilitators as program managers. BOT as program managers. In this model, the community elects the board of trustees to act as the program managers who carry out day-to-day management of the program, including engagement with all stakeholders. The BOT has technical capacity to the extent that they do not require any technical facilitation. Existing community structures, e.g., village development committees, CSOs, and existing health facilities and workers provide a platform for easy program takeoff. The BOT in this model functions dually as BOT as well as program managers. NHIS regulator, there's a flow chart also. Page 773. NHIS regulator down BOT program manager bracket responsible for day-to-day program management, engagement with stakeholders, medical audit, QA, that's quality assurance, etc. Then it goes down to community members, pay regular contribution, feedback to PMs, access healthcare services. Then you have healthcare facilities, provide healthcare services to enrollees and receive payments from PMs, regular feedback to PMs. BOT as program managers with external technical facilitators. In this model, BOT serves as program managers with external technical facilitation. NHIS accredited technical facilitators is engaged to provide technical support. The BOT uses technical facilitators to bridge gaps in technical competence. So you have the NHIS regulator, then you have the technical facilitator that provides initial and ongoing technical support to BOT as program managers. Then you have BOT/program manager, responsible for day-to-day program management, engagement with stakeholders, medical audits, QA. Then you have community members, a pay regular contribution, feedback to PMs, access healthcare facilities. You have healthcare facilities, provide healthcare services to the enrollees and receive payments. Receive payments from PMs. Regular feedback to PMs. Technical facilitator as program manager. In this model, the BOT relinquishes technical management to technical facilitators. BOT performs only ascribed functions, essentially giving policy guidelines and serves to recruit and monitor community members into the scheme. The technical facilitators implement policy guidelines. So you have NHIS regulator, then technical facilitator/program manager, then down to BOT, then down to community members, then down to healthcare facilities. This is page 775.